Assalamu alaikum rahmatullah. Today I'm going to talk about the new perspective for nutritional support in cancer patients, starting with a brief definitions about the malnutrition itself and the current understanding and future challenges. Then I'm going to discuss the causes of malnutrition in cancer patients, followed by the therapeutic goal, the ESPN recommendations, and finally we'll conclude with the call to action. So historically, the treatment advances in cancer have focused primarily on the introduction of a new substance. Lately, patient-centered treatment approach are gaining momentum progressively, including the patient performance status, the inter-individual variability in drug pharmacokinetic and genetic background. But still, in the current practice, the nutritional status receive little attention. So standard evaluation focused rather on disease-specific parameter to determine treatment procedure. So it's very important that awareness should be there. It's needed of how a deteriorated nutritional status or a high risk of malnutrition, it's an important prognostic factor for later treatment success or failure. So we can divide malnutrition into anorexia, precachexia, and sarcopenia. What do I mean by anorexia? It's associated with poor food intake and altered appetite. Also, physical limitation to food intake could be the cause, like the mucositis or GI obstruction. The precachexia and cachexia, which is the second stage after anorexia, it's associated usually with the poor intake, plus there is inflammatory cytokine playing a role. Finally, there's sarcopenia. It's the final stage. Now the body reserve, especially the lean body mass and the muscles, is lost. Here is in the other way, so we can define the precachexia, cachexia, and refractory cachexia. Now, in the precachexia, usually the weight loss less than 5%. There is anorexia, there is some sort of metabolic changes, and we can start with the nutrition counseling, fortified formulas, and the oral nutrition support. In the second stage, which is the cachexia, the weight loss between 5% and more, or body mass index less than 20 kg per meter square with weight loss or more than 2, or it's sarcopenia with weight loss more than 2%. So it has 3 definitions. Usually we can support the patient by giving formula and enteral feeding or an anti-inflammatory ingredient that I'm going to talk about it later. The refractory cachexia, which is the later stage, it's usually like the sarcopenia. It's catabolic, there is no response to treatment, and expected survival within 3 to 4 months, and palliative nutrition is recommended in this stage. There are several studies. Here is a list of the studies or the publication that illustrate the wide range of negative effects that have been reported for malnutrition, including the health and the financial cost impact. Actually, today, the malignant disorder represents the second leading cause of death worldwide. And malnutrition, as I said before, it has negative impact on the clinical outcome and the mortality in cancer patients with adverse consequences, including the impaired quality of life and higher rate of complication and worsen the post-operative period. Severity of malnutrition usually is independent predictor of short survival. So far, to what extent do we understand malnutrition? There are several studies have been conducted. One of them, a recent study in 22 medical oncology center in Italy with almost 2,000 patients, showed that 51% had nutritional impairment and 9% were overly malnutrition. So in this study, they were assessed the malnutrition at the admission of the patient. Furthermore, the author found a clear correlation between the severity of malnutrition and the stage of cancer. Another study conducted in Paris in 154 French hospital world, they found that 39% of patients were malnourished and around 42 or 43% of patients identified as malnourished and they didn't receive any nutritional support. There are two groups actually of patients. They are at particular at high risk of malnutrition, include those patients with head and neck cancer and esophageal cancer, especially who underwent resection. Also, it has been reported that malnutrition developed on more than 80% of patients with esophageal cancer, as I said, because of that sometimes after resection or dysphagia and weight loss frequently being already present at the time of diagnosis. Now, in patients with pancreatic cancer, also both the disease-related impairment of the exocrine and endocrine pancreatic function has a role. Also, the anti-cancer treatment also it can affect and contribute to the development of malnutrition. What are the mechanisms? How this malnutrition happen? What are the causes of malnutrition in cancer patients? Actually, it's something complex, a multimodal driver because of different therapeutic strategies that can occur, starting from the impairment of food intake till the increase the demand of the energy and protein, and decrease the anabolic stimuli, like for example, the simple one, which is the physical activity. So we can divide those mechanisms into three mechanism. The first one, which is the immune-related and systemic inflammation. As a consequence, pro-inflammatory cytokine will be released, and this will disrupt the metabolism of carb, fat, and protein throughout the body. The second mechanism, which is the hypoxic stress in the from the tumor. Now, the tumor hypoxia occurs when tumor cells have been deprived of oxygen. Usually, a tumor growing rapidly may outpace its blood supply, result in the region of tumor where the partial pressure of the oxygen is significantly lower than the healthy tissue. In this way, now, when such hypoxia develops, there is a complex maladaptive mechanism will be initiated, and tumor metabolism is altered, and less on oxidative phosphorylation will happen, and protection against harmful relative oxygen species is reduced. So at the end, the tumor hypoxia can lead to malnutrition. The third one, which is indirect effect of cancer or the treatment, beyond the poor intake and anorexia, usually the side effect of the cancer treatment, which can be either a chemotherapy, it can be a radiation, all these can affect the appetite. Such condition including the pain, the fatigue, dry mouth, mouth ulcer, the difficult chewing or swallowing, the thick saliva, the dysphagia, the abdominal pain, intractable vomiting and nausea, all these can affect the absorption and affect the nutrition status. So therefore, what are the new strategies to nutritional care? It's not about the food, it's starting with the screening of the patient till the final assessment, and it should be routinely. So the first step, you have to screen each patient at the admission. You have to assess and identify the signs and symptoms of cachexia, sarcopenia, anorexia. You have to measure the body cell or muscle mass precisely using specific technique like the CT, for example. Also using specific markers to assess the severity of cancer-related systemic inflammation like the CRP and albumin. Using the precise method to estimate the resting energy expenditure like the indirect calorimetry, which is expensive and not available in all of the hospitals. And finally, putting the target with the nutrition and metabolic support target for each patient. And finally, routinely, you have to go back and assess the physical function of the patient. So what are the therapeutic goals? One, it's include, but it's not limited to prevent and treat undernutrition, enhance the anti-tumor treatment effect, reduce the adverse effect of the anti-tumor therapy, improve the quality of life. And again, we should not wait more than 48 hours to assess the patient. And usually we have to start the nutritional therapy either by specific fortified food, enteral nutrition, or parenteral nutrition if the patient will be anticipated to not be able to eat more than 7 days. These are a list of screening method or tools used in the screening. Usually we use simple and validated screening tool like the Nutrition Risk Screening 2002. There is the MUST tool, which is the Malnutrition Universal Screening tool, the MST tool, the most commonly one, and that I usually use it, the Patient-Generated Subjective Global Assessment Questionnaire. And again, counseling is an effective and inexpensive intervention in combination with the other nutritional intervention. It's not a matter of screening and assessment. You have every time at each stage to counsel the patient and involve them in the decision making. This is like a part of the assessment tool. You have to every time to ask this question. If the oral route is functional, GI is functional, what is the nutritional status of the patient, and answering it by yes or no in the simple way, then finally by putting the target of the patients. So treatment, setting the goals, knowing the needs of the patient, counseling, giving the support and specific ingredient. These are the stages of nutritional care in cancer patients. Although high quality randomized controlled trial evidence is still scarce, data exists showing that timely intervention can lead to improved treatment outcome. So comprehensive therapy should include the strategies for cancer treatment while maintaining the nutritional status of the patient. And all the time, the comprehensive nutrition care should be tailored according to the need of each patient and the stage of the disease. So as I said, putting the goals, putting the target, the nutritional need of the patient, we have to calculate what's called the total energy expenditure. Usually we use specific formulas, but it's not accurate. So indirect calorimetry, it's this gold standard, but as I said, it's expensive and it's not available on all the hospitals. So we use like the formula of the Harris-Benedict equation to calculate the total energy expenditure using the resting energy expenditure multiplied by the physical factor. Then after the calculating the need of the patient and putting the target, you have to start with the nutritional counseling and the nutrition support. So it's the first and the easy way. It's the counseling. You have to motivate the patient also to adapt to the altered nutritional demand. Oral nutrition support, including fortified food or snack or specific oral nutrition supplement, also can fill the gap. So as I said, where is the evidence of this nutritional intervention? Usually the lack of high quality RCTs because of the ethics, it's not available. There are nowadays growing evidence that support the active nutritional intervention in the oncological patient, like the oral nutrition support or dietary counseling that show to improve energy intake and body weight. It's not the oral nutrition support alone and counseling, also the early intervention, the timely intervention. They found, as I said, in the most difficult patient with head and neck cancer, the early nutrition intervention yield more consistent result, and the early intervention also lead to reduction of treatment interruption and duration of hospitalization. Usually in selected patients, like in patients with pancreatic cancer, supplemental parenteral nutrition play a role. Also, supplemental parenteral nutrition is very important in the perioperative period. And lately, there are 2 studies focused on the impact of home parenteral nutrition in the patient, for example, with short bowel syndrome or cancer patient that they lost their GI function. It could help in the improvement in nutritional status and the patient quality of life. Now, we started with putting the need, counseling, early intervention, and using specific formula like the anti-catabolic and anti-inflammatory and the immune supporting ingredient. The first one, which is the use of essential amino acid or the high dose leucine, it showed that may improve the muscle protein synthesis within the context of inflammation. Also, they have been tried the fish oil, which is a good source of the long chain omega-3 fatty acid. They found it suggests that it can improve the appetite and the oral intake and the lean body mass. Usually, it's the mechanism, it's under investigation, but it could be the result of the downregulation of the systemic inflammation. The dose, usually up to 2 grams, has been studied. Also, arginine. Arginine and nucleotide, it's an immune supporting ingredient usually. It found that it could be beneficial and have positive impact. We are always hearing about the glutamine, which is also considered as part of this oral nutrition supplement. It's a semi-essential amino acid, meaning in some situation it will be essential and cannot be synthesized inside the body. It's a constituent of protein and energy substrate for the enterocyte, and also part of gluconeogenesis and the DNA and RNA. They found that the oral glutamine appeared to have no effect on mortality and the infection, but it has a good role to reduce the leukocytes by decreasing the average score and fewer day of opioid, and trend for lower day of leukocytes and less severe leukocytes and GVHD. Usually the evidence with the oral and the IV for mucositis, and the dose, it's up to 40 grams per day would be safe. These are some of the studies that assess the role of glutamine. Usually the dose up to 40 grams, and it can be given orally and IV. And finally, they found the role of the probiotic and the prebiotic oligosaccharide, that because of, the diarrhea, it's a common complication of the enteral nutrition in cancer patients and chemotherapy. And for many years, they studied that the fiber extensively investigated for its role in the preventing of diarrhea. This is something that's well known. However, there is a more now focus on the investigation of fiber blend, including these prebiotic. The quality of evidence, usually it was good in most of the studies, and it may beneficially affect a series of GI function by modulate the structure and the composition and the activity of the mucosa. So it's very beneficial to
5 minutes.
Very beneficial to put all together in a multimodal therapy and to work as a multidisciplinary approach, including the oncologist, hematologist, the pain expert, the clinical pharmacist, dietitian, nurses, and the psychotherapist. There are 2 groups of patients they consider to be at risk of malnutrition, whom a patient undergoing surgery and near end of life. Starting with the surgery patient, it's mandatory that the patient with severe metabolic risk and can be recommended even for non-malnourished patient to get the perioperative nutrition. Usually we can give it as enteral feeding or parenteral nutrition if it's indicated. So TPN, as I said, just to summarize it, it's not recommended all the patient unless the patient, for example, with radiogenic enteritis or after allogenic transplantation with pronounced mucositis or GVHD, in which they will not be able and should not take any enteral feeding. Usually, the majority of cancer patients require long-term TPN architecting, and they may receive it at home as home parenteral nutrition. So, as I said, it's recommended in the patient with severe mucositis and radiation enteritis when they intake less than 50% of the target. There is a rumor that the TPN will supply the tumor, which is wrong. There is no evidence that the TPN has deleterious effect on the outcome, or that the giving TPN will affect the growth of tumor, and it's like a food or energy for the cancer cells. These are the requirements. Usually we give up to 30 calories per kg per day of energy or calories, protein up to 1.5 gram per kg per day, and we give the carb as the recommended target unless the patient is diabetic. Lipid also enough quantity up to 2 gram per kg per day, with the physiological amount or recommended daily requirement of vitamin and the trace element. And we shouldn't forget the zinc and selenium, because most of the patients, they have a problem with the skin and the diarrhea. The ESPN guideline give high and strong recommendations for the food. When the food intake is unable, you have to support the patient and to calculate the requirement, including the nutritional intake, the weight change, the body mass index, and specifically in patients undergoing anti-cancer treatment, if oral food intake is insufficient, you have to start the counseling and the oral nutrition support. And again, the strength of recommendation was strong. So all of what we said before, it get a strong strength of recommendation in the ESPN 2019, which was the latest one. Okay, now the end-of-life cancer patient, actually, we go through the palliative treatment, because here the ethics, the culture, and the religious and the personal factors play a role. We have to include the family and the patient as much as we can. Usually we have to go with the palliative care, but nutrition, as we know, it's part of this palliative, and it should be tailored to the patient's symptomatic need, and as long as we support the comfort and the quality of life of the patient. So it doesn't mean if the patient in end of life, we shouldn't give him TPN, for example, or enteral feeding, especially if the life expectancy, which is difficult sometimes to calculate or to expect. If it's more than months, yes, we have to go and give the full nutrition need of the patient. And there is no clear criteria, as I said, when the beginning of dying phase will start. So we have all the time to tailor the nutritional intervention according to each patient. And we have to respect all the time the ethics and the cultural background of the patient and the family. So as a conclusion, call to action, we have to improve the nutritional care in cancer patient, starting with the screening of the patient and the full and thorough assessment, and putting the target, and finally will end by the nutritional intervention with individual plans. And all the time we have routinely to follow up the patient and their physical activity. Finally, for research purpose, we have to know that despite the numerous advances in the treatment of cancer patient, still the malnutrition remain unresolved and overlooked issue. In the recent guideline, the ESPN expert, they advise to update the practice and to summarize the evidence that supported such advice, and they underscore the importance of putting the guideline into the full practice and follow these key recommendations. Thank you so much.